So, good morning, everyone. I'd like to call the Health Related Institutions Formula Advisory Committee meeting to order. Thank you for being here this morning. I hope everyone is nice and warm with this cold December weather that we're feeling. My name is Kristen Mace, and I am from the A&M Health Science Center. I'm the committee chair. Please be advised this meeting is being broadcast over the internet and recorded, so I would like all attendees to please silence your cell phones. Also, since we are meeting via Zoom, please mute your connection until you're ready to speak to prevent background noise. Thank you. So let's begin the meeting with a roll call. Ms. Berger?
Okay. Mr. Alford.
Present.
Ms. Gomez-Leon.
Present.
Mr. Guajardo.
Present.
Ms. Harkey.
Present.
Dr. Lang. Mr. Lewis.
Present.
Ms. Maureen Hill.
Present.
Dr. McCullers.
Present.
Mr. Miller.
Present.
Ms. Nace.
Present.
Ms. Shear.
Present.
Ms. Smith.
Present.
Mr. Tremonte.
Present.
Ms. Withers. I see her there. Ms. Withers, you're with us, so I'll mark you present. And coming back to Dr. Lang, I believe he said he actually was going to be absent today. All right, we have a quorum.
Thank you. We'll move on to item number 4, approval of the minutes from the November 5th meeting. So I'll turn it over to Mr. Kemp.
Good morning. Is there any discussion of the minutes, the November 5th minutes? If not, is there a motion to approve the November 5th meeting minutes?
So moved.
Second.
Okay. And is there a second?
Yes, I think Mr. Tremonte.
Mr. Tremonte. Okay.
Okay.
Will all in favor? Yes. The first motion was made by Ms. Maureen Hill, the second by Mr. Tremonte. Will all in favor please say aye?
Aye. Aye.
All opposed, same sign. The motion passes. Thank you. Our next order of business is the discussion of charges, so I'll turn it back over to the chair.
Thank you. To begin the discussion of the commissioner's charges, I would like to ask each of the working group leads to provide an update for us. If we could begin with charge number 1, working group, Ms. Maureen Hill. You may remember we discussed this in detail at the November meeting. It is to study and make recommendations for the appropriate funding levels for the INO, infrastructure, research enhancement, graduate medical education, and mission-specific formulas. As part of the GME review, this work group reviewed whether the GME formula should consider a difference between outpatient and inpatient. At this time, I'd like to ask Ms. Maureen Hill to provide any updates for the group.
Yes, thank you, Mrs. Nace, and it's great to be with all of you again this morning virtually. So happy to provide an update today. In addition to the details that were provided at the November meeting, our work group did continue to discuss our charge and review data as Melita Berger and Ms. Berger received it from all institutions to refine the projected cost of the charge 1 recommendations. To add a little bit more to Kristen's comments this morning, to recap, the recommendations do include providing a standardized increase across all the formulas to support growth in each of the formulas. And that includes those tied to clinical and mission-specific research formulas. In addition, the recommendation includes an inflationary adjustment proposed for the four major formulas. That's I&O, infrastructure, research enhancement, and graduate medical education. The recommended inflationary increase is based on the average medical CPI since 2019, which is slightly under 3%, and it would be phased in over the next 3 biennia. As Ms. Ney said, one exception applies to the GME formula to really to address the significant time residents spend in outpatient settings and the largely unfunded associated costs. Given the magnitude and growing total unfunded GME cost, the work group did recommend increasing the GME formula rate by 20% above the standardized inflationary adjustment. This additional increase would be implemented in the first biennium of the 3 biennium plan. Again, these recommendations really aim to meet the critical statewide needs that I know we all know exist, to maintain and expand the healthcare workforce and ensure access to care. This in the GME formula recommendation in particular, this addresses needs in the rural areas of Texas, which I think we all recall was also a specific interest of Commissioner Rosser's that he expressed to our committee during our first meeting. And in addition, would like to add, the recommendations also complement the recommendations made by the recent Texas Healthcare Workforce Task Force that was established by Governor Abbott, and as they reported in their recent October 2024 task force report, which was titled "Building Texas's Future Healthcare Workforce." And aim to provide the necessary sustaining support for the work that the state healthcare health-related institutions do to maintain and expand our statewide healthcare workforce. With all this said, before I turn it over to Ms. Berger to walk through the funding amounts associated with these recommendations, I do want to take a moment to thank both the Charge 1 work group members, Dr. Lang from Texas Tech El Paso, Lauren Shear from UTMB, and Amanda Withers from Sam Houston for their very thoughtful and thorough work to arrive at these recommendations. Especially want to thank Ms. Berger for all the work executing on these recommendations, from gathering and running the data to really producing the understandable format that she, I believe, will now walk us through. So thank you again to all of you. And with that, Melita, I'll turn it over to you.
Okay, I'm going to share my screen. I think you all have it. Okay, I think you all have this file. I'm not sure what's going on here. Okay. So, here we have the, existing GAA on the left. And with the full targeted inflation, it would have been this column here, resulting in a total of over 4 billion. And that increases 790 million over the current funding. With the 3 biennium plan, we stagger that increase so that when you look at the orange columns here, you can see the impact of enrollment growth here in this column that results in 105 million, inflationary growth almost 200 million. And then here's the total recommendation for 28 and 29 in column M. That results in an increase of 445 million over the base, or over 26, 27 for 28 and 29. So again, that's 445 million here. And then if you look further out, you can see the additional increments that would occur for 28 and 29 and 2030 and 31, getting you back to that total of the 790 million that was projected with the inflationary increases in rates. If we move down the file, you can see those rates here and the difference over the existing rates, and how we applied a third of that difference for each biennium here. And then the weighted FTSE are here on the far right. So for 28-29, we would have 77,000 weighted FTSE. So that is charge one, and there's more details here, which you all have all seen before. So I won't go over that, but are there any questions I can try to answer now? Or anything I left out that you'd like me to highlight from anyone? Okay, well then,
I did have one question I couldn't follow when I was looking at the dental clinic education increase. It looked like it was applying a 12.7% increase to the 6 million that the institutions currently receive. Maybe I missed it, but I was trying to figure out where did that 12%, where did that tie in? I knew it was tied to the INO increase.
yes, it is tied to the INO increase, and the dental clinic is formula funded for will be formula funded for 28 and 29. And the rider language in the GAA specifies that the governor is related to that increase in INO. So that is the total amount that could result from the formula.
Okay.
So despite the math working out, for example, here to 9.5 million for Houston, they would be capped
Right.
at 6.7.
Yeah, I got that. I was just trying to tie back the 12.8.
Oh, yes. So the 12.8, if we've done it correctly, should come back to the increase in INO over the base. So we had 189 million increase over 26-27.
But it wasn't over the full three, the three planned increases. It was just for the one planned increase for the current biennium. Perfect.
Exactly. It's
Perfect.
just tied to the 28-29 increase
Mhm.
over 26-27.
Perfect. Thank you.
Yes, you're welcome.
I do have a quick question. This is just more logistical. In the enrollment column there, and not knowing how we're going to this information is going to go into the report. But if we do show the enrollment growth information in the report, should the growth in mission specific be reflected in the growth column?
We can certainly do that. I'm not sure we've contemplated how it would break out between enrollment and inflation, but we can definitely put the growth. I mean, at this point, you can see the 137 million is the increase over the base.
But if I can chime in, I don't believe an inflationary increase has been applied to the mission specific since they're, performance based. And so I think and we can certainly discuss how to present it in the final report, but it would need to be a performance growth column, not necessarily an enrollment growth, since it's just a different basis.
I'm happy to try to build something like that in there. So
Penny, would that address your?
Yeah, again, I don't know how it's going to show up in the report. It's a little hard to track because it doesn't add across with the dental and the mission specific, not adding across. So it depends on how it's presented in the formula. But we expect, if they're going to fund growth, we expect that that the mission specific is funded with that also. And,
Right, that the performance growth is funded.
the performance growth is,
right.
Yeah, the performance growth is funded also.
Right. So Melita, maybe we can take a stab at that, and we would also need to subdivide by clinical versus research mission specific formulas.
okay.
Quick question regarding the research formulas. Given the uncertainty these days of F&A, I guess is it worth including some type of hold harmless language if all of a sudden FNA gets ratcheted back and all of a sudden research numbers plunge because of that?
I would certainly be, I'd love to discuss, everyone's thoughts on that and recommendations to do so. I think it would be tricky. It would not almost need to be a one-time supplement. Otherwise, it impacts the performance-driven rates artificially, if that makes sense. So if it's a performance supplement, and we're clear about that, we could certainly discuss that, but I would hate to, again, artificially impact the performance-driven drivers of the formulas. Because the hope, of course, would be that, NIH, comes back, as strong as ever, and other factors, would improve the available, competitive research, funding to all of us. But, maybe having a conversation about bridge supplemental funding is a good idea.
I would be in favor of that, just because there is a lot of unknowns at this point. Just to have a placeholder in there, just to consider supplemental funding in the event that such that we're held harmless at current biennial levels and not decreasing because of the performance.
Yeah. I don't receive research mission specific, but I would be in favor of it because I don't see how the institutions that do could adapt quickly enough without that hold harmless agreement. I think it could really be detrimental to them and the work that they do.
Any thoughts on an amount that people would like to propose? Or a percentage?
I don't know that I would venture to say that we need to identify a dollar amount or a percentage, but just that it's written such that it's held harmless to keep at the current biennial levels, that it doesn't reflect a decrease in funding.
Melita, anything else that you would need to know to run that recommend that?
Well, I was going to ask if, I'm not sure without looking at how much detail we have on the FNA in the research reporting. Is there a dollar figure that we can identify, for example, from the FY25 reporting that's coming in now? Maybe we could look at that. I'm open to ideas here, of course.
Well, I would think that each of us could probably look at the research numbers we've supplied and get a breakdown of direct and indirect on the expense side, to give an idea of what type of dollars are in play.
I think that would be helpful. So at least maybe we would have an idea of a dollar amount or an idea of how to approach what the hold harmless estimate would be. I know the LBB would probably need that at a minimum to estimate it.
I think we would also all want to agree on what we anticipate the floor of FNA funding will be. The original proposal was 15% from OMB, which I think we all really hope won't happen. More recently, it's been proposed at a 30% floor. So I think we would all just need to agree so that we could come up with that differential.
Do we have a better sense of when we will know what it's going to be? No.
very, very optimistically, maybe in January, if Congress moves through their regular order appropriations bills business efficiently, but we won't know until after the holidays.
Okay, so at a minimum, we could try to draft a bullet point that discusses a hold harmless effort related to these indirect costs. And then hopefully have more data in January to maybe build a dollar amount out of. Does that sound like that could work?
Melita, there is an indirect cost number in our research, how much, research expenditures were paid out of recovered indirect costs on the research report that was part of the sources and uses.
Okay. All right, we'll look at that and we can provide some feedback on what we have or what we can already estimate now. Any
think-
other thoughts or?
I think as far as timeliness goes, I believe we'll have to have the report ready to go by the end of January. So we might just have to work with the information available from sources and uses and include the recommendation on a hold harmless without perhaps knowing what the final result will be from the federal government.
Okay, any other questions or thoughts on any of that? I can stop sharing the worksheet if we're done with that. All right, I'm gonna stop sharing. Yeah.
So are there any other questions or discussion items for the work group for charge number 1? Provided the bullet is added in regards to hold harmless, I would like to go ahead and ask for a vote if we feel that that's appropriate at this time.
I'd be happy to make a motion to approve the recommendation with the understanding that we'll be working on making those adjustments and the committee will be able to review the report before it gets finalized.
Thank you, Tomas. May I have a second?
Second.
Thank you, Jenny. Well, all in favor, please say aye.
Aye.
All opposed, same sign. Okay, the motion passes. Thank you, Ms. Marin Hill and everyone that served on the Charge 1 work group. Thank you again, Ms. Berger, for all of your help in getting that done. We'll move on to Charge 2A. Our lead here was Jenny Gomez-Leon. You might remember we were to study and make recommendations for the appropriate INO formula weights, including consideration of any new specialty programs for inclusion, such as graduate allied health and graduate nursing. I'll turn it over to Ms. Gomez-Leon for an update on that work group.
Well, thank you. As you might recall, we hadn't quite yet met at this time last month when we had gotten together, but we have worked fast and furiously over this last month. I think we also recognized that the work group, while we had great intentions, we didn't have enough members to contribute data from the small work group that we had. So we enlisted the help of some other institutions, and I'm happy to report that we did get a lot of the data back from those added volunteers to the group. And so we've been working on compiling the data. And I presented the data to Melita yesterday, as well as the committee. We haven't had a chance to really meet as a group to finalize it, but they did see the results through email communications. And much of the results that we had mirrored what the recommendations were from last year. Certainly, it's been a couple years, so costs have kind of increased a little bit. And so we did see some of the percentages increase, but by and large, we had 4 institutions present or provide their data. And those institutions were UT Health Houston, Texas Tech Health Science Center, UNT, and of course, UT Health San Antonio. All of us had various programs, both undergraduate, graduate, which included master's and doctoral programs. Some of the doctoral programs in both the allied health varied across the various disciplines, as well as the nursing. You had a lot of variations amongst the master's programs, as well as the doctoral programs, DNP as an example. So what we did is we compiled the costs for the undergraduates programs and compared that cost to the cost of the graduate programs. And we used an aggregated method instead of comparing each program, because methods of delivery of a particular program, even if they were the same title, same type of program, the method by which they're either delivered or the regional location that they had, the cost varied. So what we did is we aggregated all of the undergraduate programs, aggregated all of the graduate programs, and therefore the nursing programs, we compared 7 undergraduate programs to 31 graduate programs amongst 3 institutions, and derived a cost differential of about 132%. And again, when I talked about using the aggregated method, what we found is if you looked at the lowest programmatic cost on the graduate side and compared that to the highest cost of a graduate program, there was a pretty big swing. You had some programs that only cost about $33,000 to administer, but then you had some programs that were on the range of about $32,000 to $39,000 per FTSE. So the range varied greatly, which required us to really use the aggregated method on that. But amongst those 7 undergraduate programs and 31 graduate programs amongst those 3 institutions for just the nursing programs, we came up with a 132% cost differential, compared to the last biennium of 128% cost differential. So still pretty much in line, but obviously represented some of the inflationary growth that we're all experiencing. So if we applied that 132% growth or the differential for those programs against the current 1.138 weight of the nursing programs, what we would recommend is recommend a graduate rate for nursing programs of 1.508. Similarly, with the allied health programs, there were 9 undergraduate programs compared against 25 graduate programs amongst 3 institutions. And we came up with very similar results. They varied a little differently in terms of what the costs were between 24 and 25, but they resulted in the same average of 123% cost differential. And it was 123 last biennial. But you did see various swings in the individual programmatic costs. There were some new entrants into the allied health programs that we looked at. So it normalized somewhat. But again, what we would propose is applying that 123% cost differential to the 1.0 current weight for allied health programs, and result with a recommendation of 1.233 to apply to the allied health graduate programs. And I believe, Melita, you also took into account the cost to apply to the formula if those new weights were implemented. I think you said that you did factor those into the numbers that we just reviewed on the charge 1.
Well, actually, they were on a separate tab, and I'm happy to share that tab here. So let me go ahead and do that again here. So previously we were reviewing just charge 1, and now this tab is charge 1 and 2A. And so we have, this column here, column M, and it is 49.7 million resulting from the new weights. And essentially I took the percentage of graduate versus undergraduate data from last time and applied that to the current FTSE that you all have reported to come up with this estimate. And yeah, so that this is the increment for that piece, which I can't recall how much I did this just yesterday, so yes, so it's added in here.
I think you said that the total cost at that at those new proposed rates for those graduate programs resulted in about a $49 million incremental
Yes,
cost. So I think that was the total cost that we were looking at with these rates applied to the graduate programs for all, not just the participating institutions that provided their data, but it would be for all institutions that had the graduate programs.
That's correct.
We also, I just wanted to clarify that we did have 2 institutions that wanted to participate. We just didn't have their data before this meeting to incorporate into the numbers that I looked at. However, one institution did report back that their numbers compared to the percentages or the cost differentials that we were having. And then from the one that I hadn't heard back with, they were also an institution last biennium that was very much aligned with our percentages. So unless something has drastically changed at that institution, I don't foresee that it would have much of an impact to these numbers. So I do think that because of the number of programs that we compared both in the nursing and allied health areas, I do think that we had sufficient data to feel very comfortable with the cost differential as recommended. I know that I really haven't had a chance to give Kemp and John opportunities to weigh in, or Courtney. I think Courtney provided an email response on her support of the recommendations, but I think if we circulated the draft report yesterday, and so I think if we had an opportunity to look at that, happy to answer any additional questions about the calculations, the derivations that we had. If none, I don't know, Lita, do I get to make the motion that we accept these, or do I need to have an independent motion to accept these as the recommendation?
Oh, so moved.
All right.
Do I hear a recommendation?
All right, we'll take it. So at this time, I'll go ahead and ask for the first motion. I believe Mr. Tremonte provided that. If I could get a second motion.
Second.
Thank you, Ms. Harkey. Well, all in favor, please say aye.
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 All opposed, same sign. Okay, motion passes. Thank you again, Ms. Gomez-Leon, for all your work on Charge 2A, and also for the members of that subcommittee. And again, thank you, Melita, for all of your help in getting these financial documents ready to go.
Yes, thank you, Christopher, reminding me to thank everybody who participated and everybody who endured all of the data and the emails from me. So I appreciate it all. Thank you.
Okay, we'll move on to Charge 2B. This working group was led by Mike Tremonte. It was to study and make recommendations for the appropriate INO formula weights, including consideration of any new specialty programs for inclusion, such as graduate behavioral health and optometry. Mike, I'll turn it over to you.
Thank you. So the work group has met a few times. We actually were watching the work group 2A very carefully. It was the behavioral science costing data had been collected, but the reality is that there was a recognition that nobody's true cost is covered by a formula. And so we needed to come up with a methodology for sort of a right sizing it. What we did is we took what working group 2A was recommending from a nursing and allied health perspective and effectively adjusted down. We determined that under the current process, the average graduate cost they had identified was initially 64% of the formula being generated, and this is specific to nursing. And so we adjusted down the cost of behavioral health in the same breath. That actually at that point in time provided a 1.566 weight. That also was at the time when graduate nursing was at 1.138. When we adjusted it to take in consideration the recommendation of the group, we effectively that adjusted the proposed formula from 11,185 to 14,822 for graduate nursing, and in applying the same approach was recognizing 20.396 from a formula, and so it basically increased the cost to formula ratio from 64% to 85%. That ultimately resulted in a 2.075 weight. When we went through the same exercise using Allied Health, it actually generated a 2.308 weight. And after extended discussion, the thought was that we wouldn't jump to the highest amount, but would certainly be in line with nursing at 2.075. So we've come forward with the recommendation of 2.075 for graduate behavioral health. It is above the more research-based formulas associated with public health and our School of Biomedical Informatics weight, but is less than half of the other clinical departments, dental, podiatry, medical. So we believed it wasn't outside the norm to a great degree. So at this point, I'd like to stop and open that up for any questions that you may have. A secondary recommendation with that was that this formula weight would be available to, we recognize there are behavioral health programs that are currently embedded within existing schools. So some it's medical school, some it's allied health, some it may be graduate school. And the idea would be that those programs would be eligible for this behavioral health weight, and would require working with the coordinating board for assignment of new CFICE codes to be able to identify those FTSEs participating in those programs. Any questions along those lines? Nothing too controversial as of yet. Our second charge revolved around the request to consider the inclusion of optometry in the health-related formulas. U of H has a long-standing program of optometry, and they have historically been included in the GAI formula. RGV is now embarking on, Michael, will it be the first year upcoming or?
Fall of 27.
Fall of 27. So, and both Dr. McCullers and Mr. Miller was on the work group, and again we had some considerable discussion about some of the complexities regarding optometry. There's certainly some similarities to some of the other, to some of our other clinical programs. However, we really ended up exploring other possibilities, and that really were outside of our purview, but certainly something that the schools could pursue. And that was, you know, tabling it from a HRI formula perspective, but recommending that the schools work within their GAI formula construct to move it to more of a cost-based formula, much like VetMed is, given its unique nature. So it's so again, there certainly was an acknowledgement of in the current academic realm, it probably is not being sufficiently funded, but we thought that as opposed to trying to figure out how to pull it out and put it in and get funding swapped and everything else, that that it would be better to at least first pursue this other avenue. And again, I'll Dr. McCullers or Mr. Miller, if y'all had any other feedback along those lines.
Yeah, I don't have anything further to add. I think it was a very nuanced discussion, and there's a clear recognition that there's optometry has changed so much in the last several decades. It really is more like medical school now than any of the GAI programs. But the decision of the subcommittee was to go forward with the recommendation as you've outlined it, Michael.
Mike, I don't have anything else to add, except maybe perhaps how we pass that message on to the GAI side of the house, that maybe Christine can help with that conversation so we can get our message to them and how we feel the formula should be looked at.
Yes, I think I can reach out to the GAI chair and make sure that the message gets conveyed. I did have a question in regards to the behavioral health data. I know that this has come to us rather quickly, but I wasn't sure if Ms. Berger had an opportunity yet to run any numbers for the committee on the behavioral health numbers.
I have not, given that we don't have data on exactly which programs would be impacted in the existing colleges, it would take some time, and I'm not sure how much time, honestly, to figure that out, unless this is data that y'all could provide us, in terms of which, I don't know if there is a working definition of behavioral health, and then you all would be able to identify which hours would be impacted with the new weight. And maybe that's something we could ask for. Does that sound like you all could do that, or would we need more assistance from our data management folks here?
We can certainly provide it from our projected enrollment numbers to assist. I guess the key is again the existing programs at the various institutions and how those are identified. Yes.
So is there a working definition of a behavioral health program that we could consult to try to cull that data from our existing programs at our different campuses?
I will say, when I inquired internally, I got a response that from our academic and health affairs group that was not super specific, but we can try to pin that down if that would be the direction you would like. And I could send that out and then y'all could respond to it. Or, you know, Mike, if you all already have a sense of what should be included, we could go with that. Just brainstorming.
You know, I don't have a good feel for what's out at the other institutions, the variability there. We've certainly, I think we've got at least a handful of programs that have been blessed by the coordinating board and should all have descriptions available that we can certainly look at as well. So that may be a starting point.
So
Okay.
Melita, would it be beneficial to you if we all looked at our program inventory to determine any of our programs and send that specific information off the program inventory to you?
I think the only issue would be, would we be able to identify how many hours we're talking about from the data that y'all have just provided for 28, 29? You know, which FTSE would be adjusted from their existing, you know, allocation, for example, from Allied Health, carved into the new weight? Would we be able to know those numbers? And I will say, when I discussed it with AHA, they had talked about, you know, that behavioral health is usually associated with mental health care and substance abuse, including fields like counseling, therapy, psychology, psychiatry, and social work. And for example, I know that UT Southwestern has clinical psychology hours at their Graduate School of Biomedical Sciences. So again, if you want to work with, you know, those fields that I just identified and possibly give me, you know, what numbers would be carved out of the existing colleges and put into the new weight, then I think we could work with that.
I think that sounds reasonable. Would it be possible for you to send us the information that you got from the AHA to ensure that we all have the same data and we're all going after the same programs?
Sure, I'm happy to send that. And then, you know, again, Mike may have additions or clarifications to that, because when I asked, it was sort of just a quick look. You know, I'm not sure that there was an in-depth look at what would be included. So, but yes, I'll send that out.
So, Ms. Nace, I don't know whether or not we want to pass on the current information for the committee to have a little bit of time. Obviously, they're seeing this, you know, for the first time today, or we're ready to move forward. So I'll leave that up to you.
I think going ahead and providing all the information we have to everyone and kind of letting everyone review that data, and then also getting with Melita's group and providing the numbers to Melita so that she can run that and then it can be added. I think that's a great idea. I'm hoping that at least the number running can all happen. I know we have Christmas and the holidays and everything this month, but I'm hoping that could happen in the next couple of weeks, perhaps. So I would graciously ask that everyone make it a priority to send Melita the numbers that might be impacted by this recommendation. And then also, I think we'll need to come back in January just specifically to talk about this particular charge and make sure that everyone has ample time to review and discuss and ask any questions that might come up. So we might be looking in the next agenda item for a potential January date. Please, I welcome any comments or recommendations from the committee members if you feel differently about any of this.
I have one question and maybe just a point of clarification. With this pulling out we have some of those programs on the general academic side. Is this a request to bring those programs over into this way?
You know, I can state that in our report, we very specifically identified the health-related institutions.
Right.
And so, again, that would sort of be moving beyond the initial scope in that respect.
Understood.
But that's my 2 cents.
I would agree with that primarily because my understanding of the committee's focus was specific to HRI programs that were existing. And this effort was effectively to determine if those programs are being supported in an appropriate manner compared to the cost associated with those programs. And with a focus only on the HRI programs, I think that it would be held within HRI because that's where the research and the accounting support was derived.
Understood.
We did have very robust conversations, and one of the clarifying items, optometry was whether to move into the health-related institution, so that could be a yes or a no. For this particular school, there's not an option. We have to make a recommendation one way or the other of how that's going to be funded since it's a separate school. So just for those that may be more new to this process, that's not an option for us to not have an approval.
Okay, hearing no further discussion on charge 2B, we will go ahead and move forward with Melita and getting information from Melita about the programs that would qualify, and then also working on our own accord to determine the amounts and numbers to provide back to Melita, in hopes that we can look forward to January to determine if we can take a vote at the early January meeting. Okay, so moving on to agenda item number 6. We had talked previously in November about the potential for a January meeting, and I had asked that we all please hold our calendar dates for January the 7th from 10 to 12, if need be. Is anybody opposed to that date or that time slot? Okay, so if we move forward with that, is everyone okay with a virtual meeting for January the 7th, or is there a preference for in-person? Okay.
So Ms. Nace, is at that point in time, or prior to that point in time, will we have at least a first draft of the report to review as well?
Yes.
Okay.
I think Tomas is working on any maybe final adjustments to that. So I believe so, yes. So at the January 7th meeting, we would be looking at the report and answering any general questions, specific or whatnot, over the entire report, and then also take up the issue in regards to charge 2B. Okay. So in regards to the report itself, does the committee agree that myself and Tomas can assist the coordinating board to draft the committee report according to the agreed upon recommendations for charge 1 and charge 2A, and send it to everyone by email for review and approval of that? Please watch your email for the draft report so that you can weigh in with any corrections that might be needed. Okay. We'll move on to agenda item 7, the adjournment. If there are no further questions or points of discussion, do I hear a motion to adjourn?
So moved.
Thank
I'll
you.
second that.
Thank you. This formula, oh, I'm sorry. Well, all in favor, please say aye.
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 This Formula Advisory Committee is adjourned until January the 7th. Thank you.